Hello and welcome to the topic Post-Traumatic Stress Disorder in the Psychiatry module. By the end of this topic, you should be able to define Post-Traumatic Stress Disorder or PTSD, explain the pathophysiology and causes of PTSD, describe the clinical manifestations of PTSD, discuss the management approach of PTSD, and finally discuss the complications of PTSD. Let's get started. Post-traumatic stress disorder or PTSD is a particular set of reactions that can develop in people who have been through a traumatic event which threatened their life or safety or that of others around them. This could result from a car or other serious accidents, physical or sexual assaults, war or torture, or disasters such as bushfires or floods. As a result, the person experiences feelings of intense fear, helplessness, or horror. What is the pathophysiology of the brain in post-traumatic stress disorder? The etiology of PTSD is experiencing a serious threat of physical injury or death or sexual assault. Chronic PTSD represents a failure to recover from the trauma in part due to inadequate resilience. So considerable effort has been spent in an attempt to determine which individuals will have prolonged maladaptive responses to trauma. In addition, the psychological impact of experiencing a traumatic event, PTSD frequently leads to changes in the anatomy and neurophysiology of the brain. The amygdala, which is involved in processing emotions and modulating the fear response, seems to be overly reactive in patients with PTSD. Next, other factors would include alterations in neurohormonal and neurotransmitter function that have been also found to be related to PTSD. Individuals with PTSD tend to have normal to low circulating levels of cortisol despite their ongoing stress and elevated levels of corticotropin-releasing factor or CRF. Cortisol leads to decreased production of CRF. If cortisol is low, then CRF continues to be high and stimulates noradrenaline release by the anterior cingulate cortex. People with PTSD often experience feelings of panic or extreme fear, similar to the fear they have felt during the traumatic event. Patients may display physiological arousal such as tremors, sweating, agitation when they are discussing their trauma. Individuals may also present with physical injuries related to the trauma, such as traumatic amputation from an explosion or bruises in victims of ongoing domestic abuse. There are four main types of experiences here that relate to post-traumatic stress disorder. Firstly, reliving the traumatic event. The person relieves the event through unwanted and recurring memories, often in the form of vivid images and nightmares. There may be intense emotional or physical reactions, such as sweating, palpitations, or panic when reminded of the event. The next experience would be being overly alert or wound up. The person experiences sleeping difficulties, irritability, and lack of concentration. Thirdly would be avoiding reminders of the event. The person deliberately avoids activities, places, people, thoughts, or feelings associated with the event because they bring back painful memories. And finally, feelings emotionally numb. The person loses interest in day-to-day activities, feels cut off, and detached from friends and family, or feels emotionally flat and numb. So we always begin with the symptoms checklist, which includes questions such as have you experienced or seen something that involved death, injury, torture, or abuse and felt very scared or helpless? Have you then experienced any of the following such as upsetting memories, flashbacks or dreams of the event, or feeling physically and psychologically distressed when something reminds you of the event? If one has answered yes to all of these questions, then one also have experienced at least two of the following, which are having trouble remembering important parts of the event, had very negative beliefs about themselves, persistently blamed themselves and others for what happened, persistently felt negative, angry, guilty or ashamed, felt less interested in doing things that they used to enjoy doing, feeling cut off from others, and have trouble feeling positive emotions. If one has experienced at least two of these symptoms, which are difficulty sleeping, easily angered or irritated, reckless, trouble concentrating, being a vigilant and easily startled. Accompanied all this together, if these have been happening for a month or more, one may be experiencing post-traumatic stress disorder. So we begin the assessment of the diagnosis of PTSD based on history taking followed by physical examinations. Because of the frequent comorbidities, one should ask whether if the person has depressive symptoms, anxiety symptoms, substance abuse, suicidal ideation or relationship problems. As for physical examination, the patients may display physiological arousals such as tremors, sweating and agitation, and individuals may also present with physical injuries related to the trauma. As for mental state examination, factors discovered during the mental state examination may help confirm the diagnosis of PTSD, and these may include behavioral factors, increased vigilance, increased startle response, inability to engage with providers, cognitive factors, amnesia, distorted thoughts of self, others, and the world, distorted thoughts about the cause or consequences of the trauma, problems with concentration, emotional factors, decreased range of positive emotions, and persistent negative emotional states. There are also a number of self-report scales that can be used for screening or management, and these include Distressing Events Questionnaire or DEQ, PTSD Checklist for DSM-5, Screen for Post-Traumatic Stress Symptoms SPTSS, Trauma Symptom Checklist, and Trauma Symptom Inventory. There are no lab studies that are currently recommended for diagnosing PTSD, but they may be helpful in assessing for the substance use disorders which commonly accompany PTSD. While there are some consistent anatomical and functional studies in individuals with PTSD, such as looking at the imaging to look at small hippocampus, decreased corpus callosum, decreased prefrontal cortex, increased reactivity in the amygdala, and decreased activity in the prefrontal cortex. Although increased arousal is not a required criterion to diagnose PTSD, it might be measurable through studies of autonomic functioning while we are measuring the heart rate through an ECG and also through an electromyography. Now let's talk about the treatment for PTSD. Beginning with psychotherapy, trauma-focused psychotherapies appear to be effective. In a meta-analysis, it has shown that psychotherapy including trauma-focused, prolonged exposure, cognitive processing therapy, eye movement desensitization and reprocessing, imaginal exposure, and psychological first aid have shown to be useful approaches to combat PTSD. Psychopharmacological approach recommends antidepressants and benzodiazepines depending on the predominant symptom. Benzodiazepine use for the reduction of acute traumatic stress symptoms or sleep problems after a potentially traumatic event is not indicated, however. Although benzodiazepines may be popular with patients and lead to a transient decrease in anxiety symptoms, research actually indicate that they are not only not effective but may prolong the course of PTSD. Next, we have inpatient care, and this is exclusively required for patients if there is an imminent danger to themselves or others. For long-term monitoring, active treatment should occur until symptoms have abated. In addition to monitoring symptoms and social and occupational functioning, providers should also continue to assess for the emergence of suicidal ideation or substance abuse. Next would be a quick medication summary. Selective serotonin receptor inhibitors SSRIs and selective noradrenaline receptor inhibitors SNRI are generally the first-line medications for adults, but only sertraline and paroxetine have FDA approval. Antipsychotics and anticonvulsants have also been tried, and some studies show that adding risperidone to standard antidepressant therapy significantly improves outcomes in patients with PTSD without causing additional adverse effects. Moving on to complications, psychiatric and medical comorbidities are common with PTSD. Among individuals with PTSD, there are increased rates of mood disorders, panic and other anxiety disorders, substance abuse disorders, and neurological conditions. To summarize, we have understood that PTSD is a set of reactions following a traumatic event or events in their lives. We have looked at the pathophysiology and causes, which has close relationship to the structural and anatomical function as well as the neurotransmitters in the brain. Clinical manifestations, which are characterized by physiological arousal, physical injuries, and going through a symptoms checklist to look out for the clinical manifestations mentioned. We have looked at what is a diagnostic approach to PTSD, what are the investigations that can be done to exclude any other concomitant medical problems or substance use, and the approach to treatment of PTSD, which is a blend of medications as well as psychotherapy. So we have come to the end of this topic. Thank you for your time.